D.C., and an MA in Political Science and a PhD in Urban and Public Affairs both from the University of Louisville. Dr. Hanka served as Director of Master of Public Administration at USI from 2010 to 2018. Hanka has taught 19 different courses here, both at the undergraduate and graduate levels. Dr. Hanka's research interests include housing policy, community development, urban policy and governance, strategic planning, and social capital. And his academic work has been published in 9 different peer-reviewed journals. Dr. Hanka served as a co-convener of USI's latest environmental scanning and strategic planning process. And he has also worked on the strategic plan for the Rotary Club of Evansville and also the Evansville Museum of Arts, Museum and Science. Arts, History and Science. And he was appointed as the director of the Commission on Homelessness for Evansville and also for the Vanderburgh County by Mayor Lloyd Winnick in February of 2018. And is chair of the Homeless Connect of Southwest Indiana Planning Committee. He also serves as president of the Indiana Political Science Association and is a member of the Evansville Morning Rotary Club. He also provides political commentary during election seasons and local media around the area. More importantly, he has a wife, Anne, and 2 sons, MJ and David. Please welcome with a big round of applause, Dr. Matt Hanka.
The introduction. How Housing First puts us on a path to end homelessness. What's your image of a homeless person? What does this person look like to you? What does this person do? What is this person wearing? Is it someone who panhandles? Is this homeless person somebody that sleeps on a park bench? Or is it someone who lives in a shelter and eats their meals at a soup kitchen? Who among us is homeless? Do you know a homeless person? Do we even know what it means to be homeless or what to even do about it? How a homeless person is portrayed can affect how we think and feel about the homeless and the issues and problems they encounter every single day. There are many causes of homelessness, and the literature has identified a number of issues pertaining to individuals that experience mental health issues, alcohol and substance abuse addictions, perhaps the loss of employment, various chronic health conditions that may be severe and disabling, evictions from their dwellings, from their places that they rent or they live, or even a domestic violence situation. These have been identified as many different causes, and no one thing is the actual cause. Homeless population in general, 40% roughly have, in a lot of the studies we look at, have mental health issues. 80% of women who experience homelessness are often those getting away from an abusive domestic violence situation. And a lot of times the images, and I found some images of homelessness, but we do see a lot of images of homeless that usually are men. And the growing number of homeless are women and even children, the children making up 1 in 4 of the homeless. 15% of these homeless actually live on the street. Roughly about 370 plus individuals in Evansville live in shelters and are homeless almost every night. So a homeless person is defined by HUD as a person sleeping in a place not meant for human habitation, whether it's on the streets, a safe haven, or living in a homeless emergency shelter. So there are varying kinds of homelessness. About 80% of the homeless population are temporarily homeless. These are folks who have fallen on hard times, living paycheck to paycheck, may have lost a job, or need that temporary assistance. 10% are episodically homeless, and those are folks that shuttle in and out of homelessness and may have short shelter stays over a 1-2 year period. But one of the populations that I'm interested in research and I'm concerned with are those that experience long-term chronic homelessness. HUD defines this chronically homeless person as a person with a disabling condition, someone experiencing medical disabling conditions, who has been continuously homeless for at least 12 months, or has at least 4 episodes over a 3-year period, where all those episodes combined total 12 months. So the chronically homeless make up 10% of the population. They're often entrenched in the system, they're older, they have disabling and long-term substance abuse and mental health addictions, and their impact, and all these things impact their ability to remove themselves from homelessness without any kind of subsidized or supportive services. According to Randall Kuhn and Dennis Culhane, who are very prominent homelessness researchers, although 10% of the population is chronically homeless, they document that this population uses half of the total services provided by homeless organizations. So chronic at 10%, but using half the services are critical. There are factors that contribute to a person's homelessness, and we just gave some causes. And there are 2 kinds of approaches here. There's the treatment first, or the traditional approach, and then there's the housing first approach, which we'll dive into in sort of the basis of the research. This treatment first approach requires the individual who seeks housing to go through a series of prerequisites: sobriety, a clean criminal record, psychiatric stability, abstinence, an intensive service plan they must follow in order to demonstrate housing readiness before they can get into housing. Problem with the treatment at first approach is that individuals experiencing homelessness go back and forth between transitional housing and homelessness. And this transition, many of them have these chronic medical and mental health conditions that prevent them from staying out of homelessness and continue to be entrenched. So just think about this for a moment. How can someone deal with their mental health issues or substance abuse issues? Or if they have no addictions, how can they put themselves in a position to look for a job, look for employment, put themselves on a pathway towards independence and self-sufficiency? How can they do that if they're sleeping on a park bench every night? Or living under a viaduct? Or living in a homeless shelter where you're with 50, 100, maybe 200 different men, women, and children, or strangers? Imagine that. That makes it very difficult to make that transition out of this chronic homelessness. Housing first. This housing first approach, through the creation of permanent supportive housing, is a client-centered approach that houses the chronically homeless individuals and families, often the hardest to house, without any condition of treatment. A person is housed first. Housing first focuses on subsidized housing that is safe, that is stable, permanent, combined with ongoing flexible supportive services, working with case managers and social workers. These services are located on the site of the permanent supportive housing, on site, and it allows those clients for faster recovery from their addictions or mental illness or medical issues, and into community stability and independence. So working on site with that proves to be important. Housing, as someone who's a housing researcher who does this, studies how community development, it goes into the heart of housing as a fundamental human right. And as sort of a personal belief, I don't believe housing is a privilege. It's a human right, a fundamental human right. And treatment first, through the research, shows that a lot of a person's opportunity, ability to have housing is often denied, and their homelessness, their chronic homelessness, is prolonged and continued. Housing First is not a one-size-fits-all model. It includes different arrangements. Some of them are going to be for single individuals, so large families, and some units have 2, 3, 4 bedrooms. So the subsidized, safe, supportive housing combined with this ongoing flexible wraparound services are very effective for those that are on the way towards community stability and independence. Some of our biggest ambassadors of Housing First are right here in the community. The Commission on Homelessness, which I direct, works with agencies such as Aurora and Echo Housing Corporation. They're the ones who are the leaders in this permanent supportive housing movement. Evansville has 7 permanent supportive housing facilities, roughly about 170 units. Some of them include Lucas Place 2, that houses 20 units. Lucas Place 2 in this slide is for veterans, and it's right next to Lucas Place on the campus, and that has units for veterans. And so the contentional services for the veteran population are with Lucas Place 2. Vision 1505 is a facility that has actually a partnership between Aurora and the Evansville Housing Authority, where Aurora manages it, but then EHA and their property management firm manage the properties. And they house 32, this is over in the Cedar Hall neighborhood, 3rd Avenue, northern side of town. And this facility has 2, 3, 4 bedroom units. 32 units with as many as 4 bedrooms. And some of these units are fairly sizable to house families. Housing First. Another one of these is Garvin Lofts, and this is over on Garvin Street, and this just opened this past December. And this has roughly 27 units, and 12 of these units are set aside for the most medically vulnerable. So there are intentional services for those that are experiencing the worst chronic medical conditions while experiencing chronic homelessness. So we have a ways to go in terms of addressing the chronic homeless population in Evansville. That even though we did, I'll mention this, we do every year a point in time count, and this is required by HUD every year. And we count about 427 this past year, even though we did the count, the data is not available. But last year in 2018, we had 427 people who were counted as homeless. 55 of those are chronic. This unit, this Garvin Lofts helps essentially take 27 of those people, chronically homeless individuals, off the street. But even though we count 55, it doesn't mean when we go down to 55, it's over. That studies by the Indiana Housing and Community Development Authority have shown we need between 150 and 250 new permanent supportive housing units. So we have a long way to go. So one of the things that happened, and I'll share some of the research we've done, is a partnership with the Center for Applied Research. We were tapped by the Indiana Housing and Community Development Authority to do a study on permanent supportive housing, in part because of maybe the work we've done with some of our researchers who've connected with the agencies that are leaders of this in Indiana. But we wanted to look, and IHCDA wanted to look, how does permanent supportive housing improve people's lives? And they also wanted to know the economic benefits of it. Is permanent supportive housing cost effective? So I worked with a research team of colleagues across the university, so very interdisciplinary thing. I worked with folks from social work, health services, myself, Perry Burnett Economics, sociology, Dr. Priest gave us some support through Alyssa Baki, who formerly worked for the Center for Applied Research. We were on this research team that asked these important fundamental questions. What's the impact of permanent supportive housing in Indiana versus the traditional? We want to find out the way of doing it before and this new approach, this Housing First approach. What's the impact? And does this impact yield greater cost savings and more favorable outcomes than a traditional approach that uses emergency shelter and transitional housing? So these are the overarching questions we were looking at. And some of the other questions we looked at is, does permanent supportive housing decrease the use of public services, decrease the costs of those public services, and increase client outcomes, the outcomes associated with quality of life as a result of being a part of permanent supportive housing. So some of the variables we looked at are focused on emergency shelter, permanent housing costs, jail time and police contact, we were able to obtain the information, physical and mental health, and access to and utilization of supportive services. So what were some of the data and methods we used? We used face-to-face interviews with our tenants. So we did that, or actually tenants and clients themselves. We conducted interviews. But we also reinforced that with data that we collected from case manager interviews, as well as the client files. We had some interesting things. This is a very interesting little wrinkle in our study, that the data we could have obtained to answer the questions we wanted would come from what they call HMIS, Homeless Management Information Systems. That is administered by IHCDA. And IHCDA was not very comfortable with the reliability and validity of the data. This agency that is asking us to ask these, to explore these questions, and they had data that they found unreliable. It made it a little difficult, but this is how we solved that, by going into these, doing interviews qualitatively and having the backup data. And then when we did our analysis on costs, we looked at a lot of secondary data and compared it to previous research reports and studies to show. And we found out, and I'll explain in a minute, how consistent it is with what that the literature and kind of what we explored and counted, proof cost, good cost savings. So our sample size was 69, relatively low, but here's just some background and descriptive statistics of individuals that we sampled. 23.2% of the households reported one adult still living in their house. 37.7 were veterans, which is expected because you got a big population in Lucas Place too. Roughly almost 80% are not employed, and for those that were employed, 60 listed part-time and 10 temporarily part-time. But we noted for these that 1 in 4 did not have a high school diploma, but 39.1% had their high school diploma and GED. For those that, some of the statistics we came with mental health, from the data we gathered from the files and interviews, 55 had a diagnosed mental illness, depression, bipolar disorder, PTSD. And some of the mental conditions they had ranged from less than 5 years to more than 15. But in terms of drugs and alcohol usage, we came up with the majority of them reported a history of drug and alcohol abuse, and a much smaller portion reported history of treatment of such. And it was reported in many different formats, ranging from specific places to vague descriptions. So this was based on what we were given in the interviews and the files. But we show as sort of a change in and here's some we show changes before one entered private permanent supportive housing and afterwards, that when it comes to attendance at mental health appointments, we did see for those that had said their appointments, when we say appointments during interviews, it was never under 50%. We saw some decreases, but then we saw some increases for those that reported more than 50%. But more importantly, in addition, less about the data and more about kind of the stories that we heard. And these are some important, powerful comments when we talk to folks about their experience. That being a part of working within permanent supportive housing, they had this support. Before, I couldn't afford meds or counseling. I tried to kill myself. Now I have the support and I can keep my appointments. I can go and I'm not missing them. The staff remind me to go to my appointments. When I'm on the streets, I don't even think to go. I keep my appointments now and take psych meds. My thinking is a lot different since taking meds. I'm now able to walk away instead of punching someone. Now I stop and think. So these are interesting voices of this had an impact that they told us in the interviews. We saw some changes for those that in terms of inpatient mental health admission pre and post, that prior to that, after permanent support, we couldn't of course get there prior to that, but those that had experienced a lot of admissions to mental health facility, we noticed that inpatient mental health care went down as a result of permanent supportive housing. It's more or less we see it down because they're not going to utilizing expensive services, and they're utilizing the counseling that's available. You're not seeing that kind of usage there. You're seeing, for those attendance and medical appointments, you're seeing a positive change in attendance for those that are going more and more. Fewer inpatient medical admissions. You're seeing a lot of that. Fewer ER visits. Because if we think about ER visits are expensive care. And if you aren't needing the emergency room because you might not have been out in the streets that night and got cold and sick, there are some noticeable differences just in that. We know this as people who use the healthcare system. Yeah, go to the emergency room, it's going to cost you. But for someone who really doesn't have a way to afford it, that makes it that much more difficult and more costly to the system. We also notice a decline in domestic violence prior to and after permanent supportive housing. That was documented prior to that. When we asked them the impact of permanent supportive housing, we saw a decrease from about 27 to 6 in our sample. And we noticed an 82.8% reduction in arrests and jail time after participants participated in permanent supportive housing, and 47.2% reduction in the annual criminal justice usage who were in the program for over a year compared to those who were in it under a year. So individuals who are in permanent supportive housing, we noted, and based upon what we were looking at through the case law data, that we saw a reduction. The criminal history was analyzed from the tenant's case file, and we matched them with criminal histories of the chronically homeless and other studies, and saw this significant reduction. We also looked at issues of reporting quality of life, and saw through our interviews and discussions in our studies of the files of tenants having lived in their permanent supportive housing for over a year. There's no guaranteed permanent supportive housing. Yes, if you commit a felony, if you commit crimes, if you fall off the program, like any of those intentional programs, you're asked to leave. But to have 4 and 5 stick around 1 year later, for those that were reported, was magnificent. 76% reported a decrease in domestic violence. 72% reported an increase in healthy eating habits. 69% reported increased school attendance, and higher levels of involvement in their children's education increased 67%. So we saw these things. We saw not just in terms of these things pertaining to one's personal health. We saw an increase in social capital. We saw an increase in individuals having better relationships with their family members. 53% were involved more in their community because they felt connected to the community and the neighborhood that they lived in. That it's more than just a roof over their head or an apartment. It's something that I am a part of a community. 58% reported their conditions of their neighborhood as better. And 36% reported their neighborhoods to be safer as a result of their participation and involvement in permanent supportive housing. Some people, well, I didn't have these quotes up here, but I'll even read a few quotes of some people when we talk about quality of life. I'm more stable. I was so worried about other things that I didn't take care of my health. I deal with things now that I didn't deal with before. My health has been restored since I've been here. I am in a place to live and enjoy as a result of participating in permanent supportive housing. Now there's some other sides of looking at it from a cost standpoint. So we are comparing not just the quality of life, but the cost associated with permanent supportive housing. And we show that, yes, there is some, certainly when it comes to inpatient medical, we saw prior to that a enormous increase in the usage that we felt was consistent with the literature they there. We saw that, of course, using shelter was significant, but when they're out of shelter, then we have 100% savings. We saw a decrease in emergency services, inpatient medical, criminal justice usage, so the costs associated with arresting and the criminal justice system of cost of incarcerating. We did see some increase associated with outpatient medical and outpatient mental in those kinds of services. We did see an increase. But when you add up everything, and then you combine the increase associated with permanent supportive housing, we do notice we do cite an increase in permanent supportive housing. And part of that, how we estimated that, is we talked to Aurora and Hanka, and we assumed in working with them, and they noted that programs will often collect maximum reimbursement. And so what I mean by that is they're not collecting a dime from the tenant, they're collecting maximum from HUD or other providers. So they're receiving money, and the money that goes into permanent supportive housing has a cost to it. So we looked in our analysis that even though there is a decreased cost associated with the services and an increased cost in housing, it still results in cost savings overall for those in permanent supportive housing compared to the traditional approach. So while this is an increase, overall this is seen as a decrease of almost 10%.
Annually? Annual?
Yeah, in terms of the person who participates, $1,149. And so, though the saying would be is that if you have someone who would pay, kind of the expectation is 30% for rent, the more the client or the tenant pays, the housing costs, as their contribution rises, the housing costs will fall. But we assume, kind of just for conservative, that no one's going to pay, and that the provider will maximally cover everything. And even with that, offsetting the decreased costs associated with expensive emergency services, we see a savings of $1,149. So it's important from a cost standpoint. And I think what's great about the study we were doing is just, yes, there were the numbers, and the economists that we're working on, crunching those numbers, but the stories of improving quality of life and improving outcomes are important too. And we know that. Part of our charge was this is an important study that we can show policymakers to say, you increase permanent supportive housing, you fulfill that need, it's going to ultimately be less expensive per person as a result. So what are some of the takeaways from this? Permanent supportive housing leads to increased outpatient attendance in these appointments, therefore a little bit of the increased cost after permanent supportive housing, but a decrease in the inpatient medical appointments and fewer visits to the emergency room. Domestic violence decreased. You saw arrest and non-arrest encounters decreased in the usage of the criminal justice system, and emergency services decreased after permanent supportive housing, resulting in that cost savings. In addition to that, quality of life for tenants increased. We saw great school attendance, engagement with children, and even when controlling for these extra costs, there are cost savings compared to traditional means of treating the chronically homeless. Okay? So, I know that part of this is showing data and some research, but at the same time, it's important to kind of maybe a little bit of call to action. That we see the problem with homeless, and the chronically homeless are certainly an important population we have to we have to work with, and housing first, and these solutions are very important. Because if you think about the cost of doing nothing, what is the cost of doing nothing or continuing to follow this traditional model of housing the homeless? Those that are left out of the system do not receive stable, permanent housing, and they're going to be passed on to other social services. They're going to be passed on, and those social services are costly. And it costs more in the end to deal with the chronically homeless than doing housing first. So you're all here today learning about homelessness. And this is a great cartoon that James McLeod, some of you may know, he's a UE history professor and a cartoonist for the paper. And he put this out right after we did the point in time count. Volunteer, advocate, donate to nonprofits like Aurora or Echo. Volunteering allows you to see and feel the face of homelessness. But we need to do more than act on those immediate needs. We need to focus on how can we get to the root causes of homelessness, how can we address those root causes, and how can we transform people's lives. And through our research, we showed that housing first does a lot to transform lives and transforms communities. And it provides these greater cost savings and better quality of life outcomes than doing it the old way. Housing first. Thank you.